All right, it's time for another great installment of Younger Life.
I'll know when
Man, is it a great day to be alive there, young Mary Anthony. How are you?
I'm doing great. How about you today?
Well, it's a fantastic day. It's St. Patty's Day 2016.
Mm-hmm.
You are the only one wearing green in this room, and now people can actually see it.
I didn't want to be pinched.
Well, is that what it is? I didn't realize when you said
when
that.
I was a kid, yeah, when I was a kid, that's what I don't really know if that was just our school, but everybody would say if you're not wearing green, you get pinched.
Well, can I ask a question? I know your husband loves you more than anything with 5 children. So for the record, was it a guy that told you he had to pinch you? Because think about it from a guy perspective.
My friends, I remember always, I know, and it's funny. He made sure to wear green today to all the kids. I know, it's just funny, but everybody had a little bit of green on.
Well, I feel excellent today, and I hope everybody is celebrating in some way, no matter what it is. One of the things that we do here at Younger Life is we delve into a lot of cool issues. And yesterday, let's kind of recap what we did yesterday, because for the folks that may be joining us for the first time, whether they're listening or they're viewing it or all the above, let's talk a little bit about yesterday.
Well, March is Colorectal Cancer Awareness Month. And so, we're trying to, filter in a few of these important conversations that, you don't always have and you don't always think about, but it's important. And yesterday we had Dr. Ismaili on. He joined us via Skype, and he is a GI doctor. And so we were talking, about literally everything related to our digestive system. And he really specializes in the liver a lot. So we jumped into a bunch of liver issues and conditions and things we can do to keep our livers healthy, and learned a lot. He was really, really awesome.
And I want to throw this out there. Not only was he awesome, but the callers, we want you to incorporate yourselves into Younger Life.
It is so important. I mean, I made the comment yesterday, how often do you have a doctor as a resource that you can just ask a question to?
For an hour.
You know what I mean? Yeah, so please call us or text, email, whatever. Any questions that you have. After we got off the phone with the doctor yesterday, we had a caller call in and ask that today we have Dr. Seth Tatel, another GI doctor, and they wanted us to make sure we touch base on diverticulitis. So I wrote that down. We can't forget that. And
I was awesome in the spelling bee, especially in Catholic school. And in 3rd grade, I rocked it hard all the way up.
Yeah.
Diverticulitis would be one of those hard ones to spell.
It's a long one. I think it's
so hard.
Well, I think that one's a sound out kind of word.
Okay.
At least it's nice that one doesn't have a lot of hidden stuff in there, but I'm definitely interested in finding out more about it. I know very, very little about it. So, and hopefully for the caller that called in, if they're having any issues, maybe Dr. Tatel will be able to give us a few suggestions, so he's going to be great. So.
I agree. And by the way, that phone number is 219-861-1632. Again, in the 219, it's 219-861-1632. Let's join Dr. Seth Tatel. Now we're going to go to our Studio B.
That's right.
In LaPorte, Indiana. Dr. Seth Tatel, of course, at LaPorte Hospital. Welcome to Younger Life. Rick and Mary, how are you, doctor? Welcome back.
Oh, thanks a lot. I'm doing great. How are you guys doing?
Fantastic. We're so honored to have you back on. You're always a breath of fresh air. You're always so informative, and I just love your input and your perspective on life. Tell us a little bit about Dr. Seth. Let's hear about you, and then we're going to jump into a bunch of stuff, because a lot of people may not know you, but a lot of people do. So let's talk a little bit about you.
Well, let's see. Where do I begin? Well, I'm a gastroenterologist at LaPorte Hospital in LaPorte, Indiana, and specialize in digestive health, which ranges, from liver disease, which was discussed yesterday, to colon disease, pancreas disease, anything really involving the digestive system. And really love what I do. I've been practicing now in LaPorte for a little over 3.5 years. It's been my first job out of training, and it's been a wonderful experience. I learn every day from my patients, and I really, really enjoy improving the health of the community and my patients, and it's just been a wonderful, wonderful experience.
That's great. I had to ask Dr. Ismaili yesterday what got him what made him choose this path, when you're in med school? Is this something I'm always fascinated by that, kind of how did you
Sure.
get here, So is this, did you always know you wanted to go into digestive health, or was this in med school this just intrigued you? How did you get here?
That's a great question. At first, I wanted to be a neurologist, but I then realized I wanted a little more of a
Did we lose that feed?
No, I think he's still here.
Okay, good. They're going back to us. Yeah.
Yeah, I think he's still here. I think it just timed out a second.
Yeah.
Sometimes we get that little, that's the
That's
hard
a
part
little
about
burp.
Skype. Yeah, that's it. A little tiny pause, but I think he's still with us.
Absolutely.
sure.
Well, I see him moving.
I
see
know,
that-
I could see him. That's why I know. I think we still have him. That one time when we lost Dr. Leva, we thought we literally lost her. And we did not.
She was
just,
still
it
there.
was just a pause. And it was a good, 15 minutes before someone said, she's still on there. Are you going to use her? Oh, we didn't even know it.
Can you tell our producers to tell us in our
just funny.
ears?
Yeah, those little earbuds. How funny.
Well, it's some of the things, obviously, and we'll get back to Dr. Seth Tatel coming up in a second here with Younger Life. But let's chat a little bit about some of the things that you unraveled as you were looking at some of that
I have
great
to
stuff.
say, he's so young.
Yeah, he is. He's a young dude.
to be doing this many years, I was looking him up. Goodness, it's amazing. And how cool, too, I feel like, how he said he really liked neurology, but then, that's kind of where we cut out is the how he got here spot. But I think how cool that he is so young, and so I love that he said he learns from his patients every day. I think that's fantastic. So
I just had another person chime in about diverticulitis.
Oh, good.
Saying that they want us to bond a little bit and expand if we could.
Yes.
They're listening at work, cannot call in,
That's
but
fine.
would love for you guys
that's
to
fine.
kind of do that.
I had looked up, so I'm going to, one thing we're going to spring on the doctor a little, is I had looked up the 9 most common digestive conditions. So I want to ask him to tell us a little bit about these most common 9, and I'm really curious to know if this is what he finds most common. I don't even know, the study was just a general study, so I don't know where this was conducted, but are these the top 9 really that he treats in our own area, in our community?
Sure. And
I'm curious to know. So
you wanna
I'm
run
gonna,
through those? Yeah,
I'm going to
please.
run through them, and I'm sorry for those. Once we get Dr. Seth Tatel back, I'm going to have to repeat it to him. But chest pain and GERD, that is one. That was number 1.
You know what? Let's
gallstones.
let's
Go
hold
ahead.
that thought. Let's join Dr.
Oh,
Seth
good.
right now.
Good. All
Okay,
right.
let's. I'm told by my producer.
Okay.
That he is here, producing today. Sanders.
I saw him
I
again.
see him again. Dr. Seth. Now we could see him,
Let's
and
see.
we can't hear him though. That's the only problem. We can't hear him. So I just want to let everybody know. I'm just going to let these guys know really quick. I see his lips moving, but I don't hear him.
Okay.
Let's roll through those right now.
Okay, so chest pain / GERD, that was one. Gallstones, celiac disease, which I know is related to gluten, and that's been like a huge thing lately, as we talk to chefs, people are gluten intolerant, whatever. So I'm interested to find out about that. Crohn's disease, I know is a common one. Colitis, irritable bowel syndrome, hemorrhoids, diverticulitis. Oh, I just heard a beep. I think, do we have it back? Nope. Anal fissure is the last listed one. So I'm interested to hear a little bit about each of those conditions and find out what we can do to prevent those, and then I'm interested to know, again, what his little specialty is.
I am with you. So we'll focus on a few of those
He
things.
wrote a
and we'll
great
get-
article on Crohn's, by the way.
Well, and Crohn's is something that you and I discuss, and a lot of us aren't familiar with these types of things that are going on. He did write that article. Do we
He
want to
had a great
expand a
little
little bit
article.
on that article?
With him, I certainly would like to ask him about it. I just, he had written a great article on what Crohn's disease is and how to kind of, what causes it and how to kind of manage it and when you really need to call a doctor. So I certainly am not the doctor. I think
We don't play doctors, right?
I definitely don't want to claim that. So I think it's important that he tell us a little bit about that. I will tell you though, one of the funniest things I came across, and I'm not sure if it was last year or 2014, the hospital. Oh,
Go ahead.
the hospital had done a a little comedy, colorectal comedy hour.
Mm-hmm.
And I think it was so funny, to bring, to make light of such a serious situation.
And I think that there were some great logos and sayings.
There was. I saw a picture of Dr. Tatel
And what did
have
you-
it on his shirt
and-
that says, "What's up your butt?"
Yeah.
I love that. I love
Little
that he can be
Dr. Seth
candid about it
action.
too. Yeah, and I think that it is important. It is a topic a lot of people are uncomfortable talking about. No one wants to discuss their own bathroom habits. I mean, it's just truth. But there are times when your digestive system is giving you warning signs, and that can come in many different forms, and you need to certainly make sure that you're addressing this with your doctor and get to a specialist if you need to. So with it being colorectal cancer awareness month, we just really need to kind of shine a light on it in a not too serious way to hopefully be able to help someone else out.
I agree.
Sanders is getting your attention.
All right, AM 1420 WIMS 918, of course, with Rick and Mary. And we, of course, will keep you in tune with what's going on in and around the area with Younger Life right here. And some of the upcoming shows we've got, we're going to talk about some neat things when it comes to some dietitians are
Well,
going to be joining
tomorrow
us.
we have vegan chef Melody on again.
Awesome.
Now she's going to only be able to join us via Skype as well. She, she lives, I believe she said Texas, and she's there. She travels all over for giving presentations, demonstrations, and enlightening everyone about cooking healthier and better. So she's going to be joining us via Skype tomorrow. But something I wanted to point out about the article that Dr. Seth Tatel had written about Crohn's disease, he, we all know smoking is terrible for us. You know what I mean? Everybody knows that logically. We learn new things all the time, but smoking also increases your chance of developing Crohn's disease. Now, how strange is that? I'm not really sure the science behind that or the why, but it is crazy to me that smoking can affect the digestive system in that manner. So again, we know that's bad. Please definitely get some help with the smoking if you need to. That's what he comments in here. Your healthcare provider can help you stop smoking, so do that. And so I think his article is really, really, really good. He also talks about. Let's see. I'm gonna go. I really wanted him to tell us about the article, but I'm gonna go ahead and do it while we're waiting to get him back in here.
All right, let's do that here on Younger Life. Let's see if we could connect with him. Dr. Seth, are you with us right now?
Hi, Rick. It's Dr. Tatel.
Hi,
God.
Dr.
Hi.
Tatel. Thank
Sorry
you so
about
much.
that.
All right, so let's bond a little bit as our producers are here with us, of course. Thank you all so much for being a great team. Talk to me a little bit, if you wouldn't mind, Mary, as we were chatting with Dr. Seth. Let's
Right.
talk a little bit about some of the other stuff.
Okay, so first of all, I'm sorry. We lost you kind of where you said you initially were interested in going into neurology.
That's correct, yes. And then I realized I wanted a little more of a broader education and I became an internist or an adult medicine doctor. And from there, I wanted a little more of a specialization. I myself have a very mild form of Crohn's disease, so that really got me interested in gastroenterology and helping people with digestive issues, especially young people with Crohn's disease and ulcerative colitis.
Right. Okay. That's fantastic. So you obviously, this has a personal tie for you then. I mean, clearly the more you learn about it.
Exactly.
Yeah, that's great. Could you tell us, I did a little bit, I read your article on Crohn's, by the way. So can we start with Crohn's? You tell us a little bit about what Crohn's disease is and how it's treated and if there's anything that we can do to prevent it or if this is just something you just dealt with.
Right. Well, Crohn's disease is inflammation of the gastrointestinal tract, anywhere from the mouth on out to the end. And we really have a lot of theories as to what the cause is, but there is not one cause for it. We feel that more people are becoming affected by the disease. It is a very treatable disease and includes medications.
Okay.
But unfortunately, we haven't found a cure at this point. But it is a very manageable disease, and we're becoming better and better at managing disease, keeping patients healthy, keeping them out of the hospital, and making sure they live a very healthy and prosperous life.
Okay. When is it typical to be diagnosed with Crohn's? Is that something from a young child you're going to know you have, or is this something that can happen to you at any stage in life?
It's more typical to develop it in the teenage years or in the 20s. And then also there's another peak later in life, more around, the sixth, seventh, decade of life. But we commonly diagnose it in younger people. And a lot of times it goes undiagnosed or misdiagnosed for many years because the symptoms can be kind of vague, just abdominal pain. Most patients are told they have irritable bowel syndrome or just an upset stomach or a nervous stomach. So at times patients are diagnosed when the disease is already somewhat advanced.
Wow. Okay. So the yesterday we did touch base on colonoscopies a little bit. Is that how this is diagnosed as well then?
Mostly, yeah, that is the
Really?
easiest way to diagnose it, because most of the time the disease can be reached through colonoscopy, but sometimes we do need to look into the stomach and the intestine from above, because it can affect anywhere from the mouth on out to the bottom. But most of the time, it's diagnosed through colonoscopy.
Okay. I was fascinated in the article to read that smoking actually increases your chances of developing Crohn's. I was saying we all know smoking's bad for you and, causes all kinds of health issues, but I'm fascinated to know how it relates to the digestive system. I mean, how in the world does that increase your chances?
We're not quite sure. We know tobacco smoking definitely makes it more difficult to control disease. So I educate all my patients, obviously even without Crohn's disease, about cessation of tobacco.
Absolutely.
But in patients with Crohn's disease, it's very important because we can have patients on the most effective medications, yet their disease might not go into remission if they're still smoking. So that's really important for them to stop.
Absolutely.
As opposed to probably one of the few conditions that actually is improved by smoking is ulcerative colitis. So a lot of patients with ulcerative colitis get diagnosed when they stop smoking. But it's no reason to smoke or to continue smoking.
Certainly not.
But if someone has very severe ulcerative colitis, that may be one of the last things that's done is actually to have them stop smoking. And sometimes in a very, very difficult to control case, you can use nicotine patches to help control the disease in addition to other medications.
Could you tell us a little bit about, I had looked up the most common digestive system conditions, and colitis was listed. Is that the same thing you're speaking of, ulcerative colitis? Is that the same thing?
Yeah, there's different forms of colitis, but in terms of a disease that someone has as a chronic illness, usually they're referring to ulcerative colitis. But there are other forms of colitis, like an infection can cause colitis, but that generally goes away on its own. There's microscopic colitis, which causes diarrhea mostly in older women, which is diagnosed through colonoscopy, but you need to do a biopsy to diagnose that because it looks normal to the eye. So there are different forms of colitis, but it's generally mostly referred to as ulcerative colitis.
Okay.
Doctor on the show yesterday and of course today, Dr. Seth Tatel, of course, with us today on Younger Life. A lot of people were asking about, we just got a couple more text messages on diverticulitis.
Right.
And if you wouldn't mind, can you explain to the audience what that is? And kind of for a lot of us that aren't familiar with it, I'm familiar with the word, you've heard it, but can you explain a little bit about what that is and then kind of delve into that a little bit if you wouldn't mind?
Sure. Well, there are two words that get passed around, and I think people interchange them. One word is diverticulitis, and the other word is diverticulosis. So I'll start with diverticulosis, and what that is are little outpouchings of the colon, kind of little caverns in the colon that form with age. We see them, during colonoscopy as kind of little pockets, and sometimes stool kind of sits in them. And an infection of one of those pockets is diverticulitis.
So diverticulosis is just when you have those little outpouchings, they don't cause any symptoms until they either get infected or bleed. So an infection is the symptoms of the infection would be pain and fever. and that's treated with antibiotics usually. And bleeding is usually very obvious, and it's bleeding, usually bright red blood that comes through the rectum. Most Americans develop some degree of diverticulosis or outpouchings of the colon. We're not entirely sure as to why. We thought that it was possibly our diet that's low in fiber and high in fat. We thought maybe it was from constipation, but really we're really back at, to kind of really not understanding why it forms and why some people have diverticulosis and never causes a problem. Some people get multiple infections of those pockets or bleed. And at this point, there is no recommendation for dietary changes. Commonly, it's thought that, and a question I always get, oh, do I need to avoid popcorn at the movies and seeds? And really, at this point, the answer is no, because that's been disproven. That was something that was thought to be and not based on any evidence. But now we have more evidence to suggest that the diet does not affect developing diverticulosis or having a complication of it, such as bleeding or infection.
That's fascinating, because I do recall hearing that.
Absolutely. I hear about the
over the years.
seeds. Yes.
Yeah, I think
Cutting
that
the
is-
seeds out. How about, is this something, doctor, that is visible to the eye? You know, like if someone's doing this, I want to use self-examination again, because we talked about that yesterday, like women could scope out stuff for breast cancer or whatever. But in this case, is this something that a guy or a gal can scope out, you know, when they're maybe, you know, doing some self-examinations?
In terms of, sorry, switching
Like,
over to
you know,
ear.
in terms of like being able to see, you had mentioned caverns or what it looks like, or, you know what I'm saying, when this actual thing happens. Is that something that we could see with the naked eye? Is that visible on the outside of the body, basically?
No, it's not. It's only visible through colonoscopy or like a CAT scan or MRI of the abdomen.
Yeah.
Okay, cool.
Okay, if it's okay with you, can I run through real quick the list of the 9 most common? And I'm really interested to see a little bit about them and find out if these are the 9 most common in our community. It just makes me curious. Chest pain / GERD was listed. Can you tell us what GERD is?
GERD is a gastroesophageal reflux disease, or in layman's terms, just heartburn.
Okay.
It's a very common
Let's see.
condition, affects
I think,
all
I think
ages,
one of the things
young
that
to
we
old.
could
This
talk
list
about
is
is
just trying to avoid.
Yes, I would say that's a very, very
This
common
list is really being.
reason
This list
for
is
a
the
patient
trigger
to
for all
see
these issues.
gastroenterologist.
Every time I bring up the list, we lose him. So I'm sure he'll be right back. If nothing else, we'll just join him on the phone.
Okay, great. All right. That is something that obviously
So the
we would-
diverticulitis, though, it's nice to hear about that because I know people want to know. So I am fascinated that they have disproven the dietary relation to the problem, because it's been years, but I do recall hearing that. So it's nice to know that, and nice to know the. Do we have him?
Maybe
Rick,
it's
it's
Dr.
Dr.
Tatum.
Oh, good. You know, it's funny. I just joked that it's the list. Every time I
Every
bring
time
up
she
this
brings up
list.
the
We're gonna,
Bloop.
we're gonna stick with the walkie-talkie here.
Thank
Okay,
you.
perfect.
Yeah.
Could you tell us? Okay, GERD is one of these 9 listed common. Can you tell us a little bit about GERD?
GERD stands for
Esophageal reflux disease, or commonly referred to as heartburn, and it's a very, very common symptom. I
Okay.
think all of us have experienced it one time or another. Some people develop it daily, and it can be very, very uncomfortable for patients. And so it's a very common reason for someone to see a gastroenterologist. Commonly, primary care doctors treat it, but if it's very severe or develops it later in life, we have to clearly make sure there's no other problems going on that
Right.
could have led to that symptom.
Okay, gallstones is listed next.
Gallstones it's common. It's probably more common for a surgeon to see, but a lot of us have gallstones that never cause any problems whatsoever. But if a gallstone gets out of the gallbladder and can get caught in the bile duct on the way out of the liver, that can cause severe pain and jaundice, and that's something that a gastroenterologist.
Okay. Just curious, with the gallstones, is that automatically, if you do have that situation, is that automatically surgery is the only treatment, or can someone suffer gallstones and not have to have their gallbladder removed?
If a gallstone gets out,
Yeah, if that happens, is that
yeah,
automatic?
that would be an indication to one, obviously get the gallstone out of the bile duct,
Right.
but that would be an indication to have the gallbladder removed. So
Okay.
any symptoms that develop as a result of a gallstone, such as pain in the gallbladder, a gallstone getting out, either causing pancreatitis or just pain or jaundice, is an indication to have the gallbladder removed.
Okay. The next listed is celiac disease. And you hear a little bit more about that lately. At least I feel like it's a little bit more out there. That's related to gluten, right, doctor?
That's correct. Yeah, that is
A gluten allergy.
Right.
The incidence of celiac disease is actually 1 in 100. Although I feel like nowadays people feel that, half of the population has celiac disease.
I know that's what it sounds like.
Yeah.
It seems like so many people are saying I'm gluten intolerant, or I feel like my children
Right.
are gluten intolerant, and that's why I was curious: is it really that common, or how would they even diagnose that?
Well, as I mentioned, celiac disease is 1 in 100, but there is the diagnosis or the theory behind gluten intolerance, meaning that there are people that still have symptoms with gluten in the diet, although all of our tests are normal. And we feel now that based on some recent evidence that and studies that there is a condition where people have symptoms with gluten, and when they take gluten out of the diet, they improve. We just
Okay.
don't have a test for it, unfortunately.
Okay.
So if a patient comes to me and they tell me that they feel better without gluten in their diet, then they should just proceed with that. Unfortunately, it's just a little more of a restrictive diet, a little more costly at the grocery store,
Yeah.
but there's really no harm in excluding gluten from the diet.
Okay. Very good
Okay.
point. We did touch base on Crohn's. We touched base on colitis, irritable bowel. Was listed, hemorrhoids. I think people pretty much know what irritable bowel is. Hemorrhoids too, diverticulitis, and anal fissure. Can you tell us what the anal fissure is? I'm not really sure.
Yeah.
Exactly.
An anal fissure is a tear in the skin around the anus, and the symptoms are generally very severe pain. I almost just describe it like as an ice pick in that area, and also can have some bleeding, commonly caused by constipation, which can then create a tear. And it's difficult because it's very painful, and a lot of times they don't heal completely. But most of the time, with correcting the underlying problem, which a lot of times is constipation, and a certain medication applied topically, most patients heal up without needing any surgery.
Oh, good. Okay, that was my next question. Do all of these require surgery? Obviously, they don't. It sounds like
Well,
there's such varying
and
levels.
I don't mean to like spin it a little bit here, but we just had a text message asking specifically to ask the doc, didn't want to call in because they're at work, kind of attitude, just about bathroom, business, when they're in the bathroom, and are there any signs, particularly when they're going to the bathroom, that they should feel that they should call their doctor, whether it's the color of their stool, whether it's the way things are happening, whether they're experiencing pain, and that's what it was. It was pain, stool, and that's what they asked. I'm just going to throw that out there. Can you kind of elaborate on that? Is there anything that we should know, especially color? I think people are, all freaked out about that, and we're all adults here, so we're bonding with Dr. Seth on this.
Well, first off, not everyone looks at their stool. If you ask around, there are lookers and flushers. I think everyone should be a looker and then flush.
Yeah.
It's important to really see what the stool looks like, just like the urine, because that can be an indicator of underlying medical problem. So in terms of color, a couple colors that you should be aware of that would be abnormal and potentially a concern would be bright red blood or any form of blood coming out into the stool. Also, black stools, black tarry stools can be an indicator of gastrointestinal bleeding coming usually higher up from the stomach or intestine. So that's a reason either to go to the emergency department or contact the doctor immediately. But certain color, one other color would be like a very light or pale, like clay colored stool. But generally when someone has that, they're very jaundiced. But beyond that, green stools, any form of brown, yellow, generally are all within the spectrum of normal.
Okay.
Thank you.
Yeah, that's good. That's good to know. And just strange. I'm just curious. where I understand the black tar you said is, actually blood higher up. Where does the color, how does it get color anyway? I mean, besides the blood, obviously bright red, you're going to know. The black tar you just said, is blood higher up. That makes sense. Is it our diet as far as colors in general?
Color comes from the bile, actually. So someone who can't produce bile, they're jaundiced or have a blockage, their stool eventually will turn very pale and clay colored.
Okay.
So it's the bile that becomes digested, turns brown. If you have a very
Interesting.
fast digestive system, then your stool can be green from the bile that hasn't changed. So bile is a green color. And so that's why a green stool is still within the realm of normal. It just means that things are moving through quite fast.
Fascinating.
Dr. Seth, someone, Tony, is listening online. Can you ask the doc to explain the difference between IBS and IBD?
Oh.
So if you wouldn't mind, can you kind of elaborate on that? Thank you, Tony.
Yeah, I feel like we should change the acronyms because it's confusing. So IBS is irritable bowel syndrome, and IBD is inflammatory bowel disease. And I touched on that a little bit before. Inflammatory bowel disease actually is made up of Crohn's disease and ulcerative colitis. So there's actual inflammation when it's examined through a colonoscopy or endoscopy or by other methods. There's actually inflammation in the GI tract. You can see it, it can be biopsied and demonstrated. With irritable bowel syndrome, a patient presents with certain symptoms, whether it's abdominal pain, constipation, diarrhea associated with it, or diarrhea that goes back and forth with constipation. Yet the gastrointestinal tract looks normal. It's normal if you biopsy it. There's no evidence of any inflammation, but yet there are symptoms that accompany it. So we don't understand it entirely. We think that it has a lot to do with the nervous system and the GI tract and the way patients experience the food and gas and distension of the GI tract versus someone who has no symptom.
Okay, that brings a good question that I have. Is a healthy lifestyle, meaning a well-balanced diet and exercise, the best tool to keep our entire digestive system healthy, or is there something additional we can do? We kind of touched base on vitamins a little bit with Dr. Ismaili and probiotics, and again, probiotics. If we could get into that a little bit again next and find out exactly what does a probiotic do, in our system. So first of all, the healthy lifestyle, is that our best tool, or is there something else we can do to?
A healthy lifestyle is definitely our best tool. At this point, there is not a lot of data out there suggesting specific diets for gastrointestinal health, unless there are particular symptoms or conditions such as a narrowing in the bowel. You wouldn't want to introduce a lot of roughage into the gastrointestinal tract. But a balanced diet, a calorie-controlled diet, which I think is something that is very important, especially in liver disease and fatty liver disease. But apart from that, there's not necessarily a specific diet. I touched on celiac disease and gluten-free, but even in Crohn's disease and ulcerative colitis, we haven't found a specific diet to help control that. There's been some dietary breakthrough in irritable bowel syndrome for some of the symptoms, such as bloating. But other than that, it's really just a balanced diet and calorie-controlled diet.
Okay, and then on the probiotics, can you tell us what a probiotic is and exactly what it does to aid the digestive system, I guess?
Well, probiotic is a concentrated form of bacteria, usually in a pill form. It can be made up of different sorts of bacteria to different degree or quantity. We feel that nowadays we're discovering that the bacterial makeup of the colon can really predispose to certain medical conditions, whether it's obesity or inflammatory bowel disease, but we're not quite there yet in knowing how to prevent disease or control or manage disease by altering the bacteria. There's some support for probiotics in certain conditions like antibiotic-associated diarrhea, a little bit of data supporting prevention of infections in the colon like C. diff, diarrhea, and a little bit in ulcerative colitis. But for the most part, the data is lacking. I do not recommend probiotics across the board for patients.
Okay.
If they've noticed improvement, we don't think there's much downside other than cost to taking probiotic. But I'm not a big proponent at this point. I think it's just a little too soon to start having patients just buying this over the counter to
Right.
treat their symptoms that haven't really been shown to improve with it.
Here's
Very
a
good.
question for you from one of our listeners. Basically, does stress kind of affect the way your digestive system works, Dr. Seth? I'm just curious about that, and that is a great question. A lot of us have stress.
I think we would all attest to that. Stress can alter your bowel habits. If you have to go in front of a large crowd to speak, we kind of feel the little grumbling in our stomach and maybe some urgency to go to the washroom beforehand. So we all know stress can do that. I don't think we understand entirely how or why that occurs. I do see some stress associated with like Crohn's disease, inflammatory bowel disease, although it's unlikely to be the initial cause, but definitely increase in symptoms with stress. But yeah, I think stress can affect all of our organ systems. We know the heart
Right.
and that sort of thing. So it's important to learn ways to cope and deal with stress in a healthy way. Exercise and diet and communication, all good things for that.
It brings up a good point about Crohn's disease in general. I was looking at it's recommended to journal what you're eating, so you kind of find a pattern in your what might trigger a flare up for you. Is it the same with stress? Should someone be journaling that as well? Would that assist at least them having an idea, maybe how to better manage that?
It can definitely be helpful. Really, the mainstay of treatment and managing Crohn's disease is medication and
Okay.
taking it as directed and not stopping it without consulting the treating physician. But stress management is definitely an important part. There's increased depression and anxiety in patients with chronic medical conditions, especially Crohn's disease and ulcerative colitis, affecting predominantly the young population. So I think chronicling that and learning how to cope with it is definitely very effective in terms of just leading a healthier and a better lifestyle.
Good point.
Here's a question for you on colonoscopy. Since March is Colorectal Awareness Month, and we've been chatting about this, we know how important it is. Someone listening right now out there or viewing and saying they need to take that first step, what kind of advice would you give them? Is it different today than it was even 5 years ago? Can you kind of talk about that a little bit? I'd be curious to hear what your insight is on that, please.
Sure. At first, I would state that it's just really not as bad as you think it will be. I always say, and it's been mentioned before on previous programming, that the worst part is the prep or the laxative portion of the procedure, which is taken the evening before the procedure and the morning of. That has improved dramatically over the last several years. It used to be a 4-gallon, sorry, that would be even terrible.
I was going to say, wow.
4 liter or 1 gallon quantity of fluid, and now it's 2 liters or a half a gallon.
Oh.
So that has improved, and it used to be that patients would have to take it all the evening before, and now we're splitting it, doing half the night before and half the morning of. The procedure is generally done with deep sedation, so there's no pain, no recollection. Patients usually wake up from the procedure wondering when we're going to get started. I always offer them a second procedure if they want.
That's
But
funny.
it's not that bad. It's just really making that call the first step. Once you meet the doctor and kind of get it scheduled, it's very simple. It's just making that first call, getting your appointment set
so
up,
important.
and realizing that we're all at risk. It's colon cancer risk is 1 in 19, second leading cause of cancer-related death in the United States, and it's preventable and it's curable at early stages. So it's just very important to have this done.
Absolutely.
So what would it be, from both men and women have these, doctor? That's the first question. And secondly, roughly you hear 50 is the age, but I have friends, I'm 49, so I have friends that have done it in their 40s just because they've done it in their 40s. I'm just
curious to know if there's risk factors that would cause you to get
Rick,
it done
when's your
earlier.
birthday?
Birthday is November 10th, Dr. Seth.
See,
All right.
Why are we going to do one
we're
live
planning
on the air?
it. There we go. We're going to plan it.
It's
Happy
up to
birthday
you.
to you.
If Dr. Seth does it, I would trust.
There we go.
I'd have no problem.
That's perfect.
All right. Well, just to address. Oh, sorry. You can go.
No,
No,
that's what I
please.
was, yes, please. That's what we're really curious
Okay.
about as to what, we know 50 is like the targeted age, but what risk factors would make someone have to come in earlier?
Well, the major risk factor is age. So the current recommendations for average risk American is to start at age 50. Men and women are at risk, so there's no difference there. You mentioned that some of your friends in their 40s have had a colonoscopy. They might have had one due to a family history of colon cancer at an earlier age than 60, or possibly was they had other symptoms that needed to be investigated, such as rectal bleeding or diarrhea or abdominal pain. But an interesting study that just came out was that we're seeing colon cancer under age 50 in about 15% of cases. So that's, I think, a lot higher than we thought. And there's discussion about maybe reducing the screening age for average risk more toward a 45 point, which is recommended for African Americans, because they're at more risk. But that's currently not a guideline recommendation. But it is kind of interesting and concerning to see that statistic.
It is concerning, and I'm curious, just for I realize this is strictly your own opinion, but do you think that's just culturally related to our American diet?
We're not sure.
Good question.
It's scary, though. That
It's very
is
scary. I think what we're seeing is as other countries in the East are transforming more to a Western diet, that their colon cancer rates are increasing a bit. So it could be dietary, and as well as someone who moves here to the United States ends up assuming the risk of average risk American for colon cancer. So it could be dietary, environmental. Nonetheless, the risk there. It's not going away, and so we need to do something about it. And screening is what we can do.
Absolutely.
So the procedure, when they're actually doing this colonoscopy, doctor, they're kind of basically looking for certain things. We've heard, different things that they're able to, get rid of, I guess, polyps
the
or whatever.
polyps and stuff,
Can
you
you
remove them.
describe it? Because, what was it that was mentioned to us? Like it's like a 6 feet trek.
Well, Dr. Smalley said, yes, I was shocked to hear that the actual tube that is used is 6 feet long in length. So, I was surprised to hear that. And I think in a way that's comforting just to know they're really getting a good look, all the way. They're going to make sure that anything that's dangerous there is removed or even questionable. And I think that's comforting, just scary, but still comforting.
Right. Well, the colon cancer just doesn't appear overnight, and it stems from a polyp, which is a small growth. I kind of liken it to like a skin tag, that we can see, although we can't see them in the colon without a colonoscopy. It takes about 10 years from a polyp to form to turn into colon cancer. And so if we can find these polyps in their kind of infancy state and remove them, we can effectively prevent the progression to colon cancer.
That's great to know, because I'm just saying, so let's say maybe in your 40s or your 50s, because I made this comment a couple times, I would have no problem doing, a test now. I don't have a problem with that, but I'm just, I'm waiting till I'm the big 50 in a couple of months. And then we're going to do it on Younger Life.
That'd be great. That would be great. It would be really funny. Talking to anybody that's under sedation is so fun.
Yeah, thanks. Appreciate it. Ask them the question.
We're here to support you.
Yeah, right.
I think it certainly is important. I'm curious to know, Dr. Tatel, have you noticed, as there is so much we learn so much more about cancers and ways to prevent and, promoting the colonoscopies. Have you noticed an increase in your own screenings that your own office does? I mean, do you find that more and more people are actually saying, okay, you know what, even though it's a little intimidating, just because it's different, but they're doing it anyways because they are you finding that more and more people are seeing the importance of it?
Yeah, that's very true, and that's true nationwide. The screening rate right now is about 60% nationwide. It's going up, so that's a great thing.
Good.
The biggest effect in the acceptance of screening and the discussion of it was when Katie Couric had her colonoscopy on national television, which really told the public that anyone's at risk. And so now it's something I think people do talk about, and it's a common thing. I hear patients when they come in, just, if that's something that can help me and keep me healthy, I'll do it.
Absolutely.
So it's really the primary care physician is probably the best person to bring up the subject of screening because they've had a relationship with the patient. But I have family members bring in their family members for screening, mostly wives bringing their husbands reluctantly in, but that's important. And it doesn't matter how you get there to the office or to the screening, as long as you do it.
Do you guys have a ton of, screenings going on? I mean, your office, do you guys do a lot of those? I mean, is there an average like 20, 30, 40 a week, or is it just vary?
It varies a little bit, but that is a large percentage of what we do is colon cancer screening and prevention. I'd say it's about 30% of a gastroenterologist's practice doing that. So it's important, and and even so, we're not doing enough of them, really. If we're only getting to about 60% or so of the population.
Right. I'm encouraged to hear that it is that high, though. I was, I'm glad to hear that it is becoming more of a, it's just like women don't want to go for a mammogram, but it's still important. You need to do these things.
I agree.
So I'm encouraged to hear that it is a 60% rate. And of course we want to shoot a lot higher, but I feel like that's a good start. You know what I mean? So I'm encouraged. And would you mind, doctor, to give out your office phone number and address for anyone that might want to call you and get the ball rolling? Sure.
Yeah. So my office is located in what was the Heritage Building next to the hospital. It's a Heart and Vascular building. The address is 901 Lincoln Way, Suite 306. And the phone number is 219-324-0875.
Fantastic.
Are most of those procedures, just kind of thinking out loud the way people think in America,
Absolutely.
Are most of these covered by insurance, doctor, for the most part?
Yes, they are for the most part. Some insurance plans have a preventive care component where they'll cover colonoscopy 100%, and others don't, where it could apply to the medical deductible. So you have to check the particulars of the insurance policy. But as long as it's done within guideline recommendation, that's why if you were to have yours now, the insurance company probably would send you a bill. Because you're not 50 yet. So I don't recommend screening earlier, although you're not without risk before the age of 50. But based on current guidelines, insurance companies abide by those and will then generally cover starting at age 50, unless there's a family history, of course.
That's awesome information. And I think the thing that's sticking in my mind, I just keep going over it, is you can be at risk in that 40 range.
Well,
but
yeah,
also
that's very scary.
Just some of the stats and the way that he was backing that up.
I want to clarify, doctor, when you say family history, are you talking parent or sibling only, or is this parents, grandparents, blood aunts and uncles? At what point is the family history not as, I don't want to say directly related to you, but if I have a cousin or a great aunt that had or uncle that had colon cancer, at what point do I say this is in my family history that I need to be worried about?
I think to keep it very simple, it would be a first degree relative, meaning a parent or a sibling, who has had colon cancer diagnosed before the age of 60,
Okay.
then the individual should have a colonoscopy beginning at age 40
Okay.
or 10 years before the diagnosis of their loved one, whichever is earlier.
Okay. Okay. Well,
But once a family member has had it after age 60, screening age doesn't change, so it'd still be
Really?
age 50.
okay.
There are some other kind of genetic conditions that can affect families when there's more than 2 or 3 people affected, but that's it gets a little complicated. You have to do a family tree and kind of understand what the risk is. But just to keep it simple, we're talking about parents and siblings.
Okay.
Awesome.
Good point.
Well, you are always awesome to have on the
Thank
air,
you so
Dr.
much.
Seth Tatel. We so appreciate your time. And thanks
my
to our
pleasure.
producers, 219-324-0875. We'll have all this information up on Younger Life as
Absolutely.
well.
And I hope if nothing else that our listeners today say, okay, those that are of screening age,
Sure.
please do it.
Just
Sign
do
up.
it.
You know what? Really, it's encouraging and it's so important. And, as we learn more and more, it's obvious. It just is-
You brought up
needs
Dr.
to be done.
Seth's shirt that you said you saw.
I saw a really cute picture you had, the what's up your butt. I thought that was
I
funny.
love that.
I know the hospital, the LaPorte Hospital had done the colorectal comedy hour. Was that last year or 2014? But
That was last year.
was it? Okay. I
Are we
knew.
doing one again this year, Dr. Seth? Come on.
No,
I just
maybe
think
next
it's
year.
funny. Yeah, maybe next year. There we go. I would love I would love it if they did, so we could go there. I think that would be really funny, and again, it brings light to such a serious topic, so it's important.
Thank you,
But
Dr.
Thanks for
Seth.
joining us.
Have a great day.
Oh, my pleasure. It's great as always.
Thanks.
Appreciate it. All right, Younger Life.
so awesome,
he
too.
is absolutely great.
You know
And
what
I
makes
really
me curious?
appreciate
Does he
that.
wear that T-shirt around? Wouldn't that be funny?
Well, yeah,
Wouldn't that be funny at the grocery store? You see him in the "What's Up Your Butt" T-shirt. That would be really funny.
absolutely. Well, I'm liking that. Well, coming up tomorrow, in a quick note, because we've only got about a minute left in the show, we're going to have Chef Melody.
That's
Let's
it.
talk about that for a
Vegan
minute.
Chef Melody's going to join us via Skype. She's in Texas right now, so she's going to join us Skype. And so anyone that has questions on labels, nutrition in general. Oh no,
Yeah, I know.
I just realized I shut that. How funny.
I was like, okay, well,
Whatever.
you're in your own world, kid.
Anyways, she's going to be on with us tomorrow, so
Cool.
that'll be a good show.
All right. So on behalf of us all here at Younger Life, we so appreciate it. YoungerLife.org is the website to go to.
That's
Great
right.
articles, healthy
Lots
recipes.
of good information, and yeah.
It's
go
always
there.
great to see you.
Oh, you too.
Happy
Thanks.
St. Patty's
Yes,
Day.
you too.
Be safe, designated driver. Stay healthy. Stay younger, right?
That's right.
All right. We'll see you later. I'm Rick
Thanks.
Federici.
I'm Mary Anthony.